do the mastectomy and you send it off to the pathology people, what is the different kind of results that you get there? So will there always be cells left, or most of the time nothing
After chemo?
Yeah.
So it depends on if you have a HER2 positive cancer, estrogen negative HER2 positive cancer, about 60, even as high as 65% of patients, by the time you do their surgery, you don't want to see any cancer there, or you shouldn't see any cancer there. And that means that the patients had 4 cycles of red chemotherapy, anthracycline, and they've had 4 cycles, which means 12 weekly doses of paclitaxel usually, and they have had Herceptin with that paclitaxel. That is probably the best regimen to get rid of that cancer. And if you're in a very good medical aid, you can add pertuzumab to the Herceptin or to the trastuzumab, and that would push it up to maybe like even 72% of patients that should have no cancer left in their breast by the time you do their surgery. So theoretically, you don't have to do a mastectomy. You can just remove the bed of where the cancer was to see what's left. Okay. If you have a triple negative cancer, you should have about sort of 50% of the patients, where maybe sometimes even a little bit more, but that there should be no cancer left behind, not even one cell. If you have an estrogen positive cancer, remember, estrogen is still the thing that drives that cancer. Even the bad ones are not that chemosensitive, so you'll maybe have anything between sort of 10 to 15, 20% maybe that would have a complete response, that there's absolutely nothing left. But remember, they still have to have the estrogen treatment.
So now you're left with a few cells, the other percentage. So what happens now? Do they need to get a mastectomy to get rid of that, and radiation to make sure that it's now all gone?
So everybody that has breast cancer will need to have surgery after they've had their chemo or the upfront treatment. Okay, so you still have to have an operation. You can't have treatment and then everything shrinks away and then you just decide, okay, now I'm going to go on holiday. So everybody has to have surgery. Okay. Now, if there's something left, we will then make a decision to say, okay, so obviously you need follow-up treatment. You can't just, you're not happy that everything's dead. So if you're an estrogen positive, you will continue with your anti-estrogen treatment. If you're HER2 positive, you will continue with HER2 treatment. But if you're triple negative, you don't have any of those things. Those are the patients that you would then say, okay, maybe you should have a chemo tablet and continue with that for maybe even the data now says maybe another year of taking a chemo tablet. And we add things like, for example, bone protecting medication, things like Zometa or Zobone or a cluster. And we know that also reduces the risk of the cancer coming back. So we add other treatments to try and reduce that risk, because the triple negative patients don't have follow-up treatment that can help and protect them, like we do with estrogen positive cancers or with HER2 positive cancers.